Welcome. I welcome you on the behalf of IP Delhi office this Sunday morning. We all know this how the important is Sunday. And Sunday morning we started with this academics. And today is the first session of mastery classes in pediatric hemato-oncology. IP Delhi is very instrumental in conducting various mastery classes in last 2 years. And this is our third module this year. And I thank Dr. Manas Kalra sir to make this module perfect one. And it is basically a practical approach for a general pediatrician. Our aim is to just upgrade your skills, not to teach you. And we have done lots of work on this part. And we thank Dr. Manas for beautifully design this module so that every delegate should get the benefit from this module. I welcome Dr. Anand Prakash sir, the today's speaker, and Dr. Jagdish Chandra sir also. He is joining very soon. Dr. Jagdish Chandra sir is teachers of teacher. He is our mentor, very senior person, and very humble human being. So we have esteemed faculty all throughout this module. So I request each one to please take your notes and follow their advices, guidelines. They are very expert in this field. So before that, I would like to ask our President Sir, Dr. Ajay Gupta Sir, to give a welcome address. Then we'll pass to the Dr. Manas Kalra Sir to introduce the today's speaker, and we'll start the session. And we are very particular in the timing for the session. Thank you so much. Over to you, Dr. Ajay Sir.
Uh, Good morning. Thank you, Dr. Dinesh. Good morning to all the respected faculties and dear delegates. Today is the first session of the e-master classes in hematology and pediatric oncology. We welcome Dr. Anand Prakash, who has joined, and Dr. Jagdish Chandra sir will be joining little shortly. I request Dr. Manas, will request Dr. Anand to start the session. In the meantime, Dr. Jagdish will be joining. I request Dr. Manas to please take over and start the proceeding and introduce the speakers.
Sure. So thank you, Dr. Ajay and Dr. Dinesh for this wonderful initiative. At IAP Delhi, we felt that, we did a e-hematology session a few years back, and it was a super hit with, I think some of the sessions on YouTube have more than 20,000, 30,000 views. So Dr. Ajay Gupta's vision was to recreate that. And this time we have put a case-based module kind of a thing for all of you. I'm sure you will learn a lot. You all know hematology. You all practice hematology in day to day of, your practice. But I think there are certain things which need revision, which need revisiting, newer concepts, and making sure that, whatever errors we make in our life, those are all gone. So to give the best to our patients and keeping children at the center stage for everything. So today we have got two very esteemed speakers, and the topic is nutritional anemia, the most important topic for any pediatrician. My dear friend Anand Prakash and Dr. Jagdish Chandra also has joined. So welcome Jagdish Chandra sir. Jagdish Chandra sir is professor, former director and head of Kalavati Saran Children Hospital and Lady Harding Medical College. He's teacher of teachers and has taught me also so many things, not only in hematology, but also in life. A big hello and regard for Jagdish Chandra sir and Anand, my very dear friend from St. John's Children Hospital. He is doing an amazing job there with a wonderful team, looking after children with blood cancer, bone marrow transplant and immunodeficiency disorders. So over to Dr. Jagdish Chandra sir and Anand. And if Dr. Jagdish is having some glitches, I would request Anand to please kickstart with his presentation, and Jagdish Chandra sir can join later. There is a post test, and I'll be posting that. I don't know if Anand and Jagdish sir have got some questions, but we anyways have one little post test for all of you. We'll put that in the WhatsApp group for the delegates so that you all can answer and maybe take it up later as well. Thank you.
Thanks, Dr. Manas. Thanks to Dr. Ajay and Dr. Dinesh, and all the participants to coming in on this Sunday morning. Would you want me to start? Shall I start?
Yes, yes.
Okay.
Please go ahead, sir.
So let me just share my screen and also thank IAP Delhi again for this opportunity. I hope my screen is visible.
Yes, sir. Yes, sir. Visible.
Yes, Anand,
Okay,
visible.
okay, great. So I do remember being part of the previous IAP Delhi activity also, and I'm glad that so many of us have been able to join today. What I thought I'll do is, Jagdish Chandra, sir, of course, is the doyen of pediatric hematology in this country. Sir has been part of this very, very important guideline statement from the IAP along with the PHO chapter. I thought I'll take you through some of the important cases of megaloblastic anemia. These are all things which I'm sure on a day-to-day basis you and I regularly see. We look at some of the biology of the clinical manifestations because sometimes megaloblastic anemia can be very straightforward. And yes, looking at the patient, it's almost like a PG exam spotter. हाँ ये तो megaloblastic ही लग रहा है. This is infantile tremor syndrome, the typical adolescent girl. But sometimes, like Manas said, things can be a little tricky. And whether you're working in a primary care center, a pediatrician, or even in a hematology unit, sometimes some of these diagnosis can be a bit tricky. Where can we make the appropriate diagnosis? And some very, very important, not only clinical, but also lab aspects, because many times we tend to fall back on labs a lot in hematology. So we definitely need to know when does the lab help us and when is the lab a bit tricky, where we shouldn't fall prey that इसका तो B12 low है, इसको B12 problem ही होना चाहिए. That part we'll sort out today. And I would definitely request all the participants, I'm sure many of you have already gone through this document. This was prepared by some of the leading luminaries of the IAP PHO chapter with Dr. Jagdish Chandra sir leading the way. This is a very good document for all of us to fall back on. And we'll keep referring to that document to guide us as we treat our patients. So the first case is something which I'm sure you and I would have seen. In fact, nowadays, 10 years ago or even 15 years ago, when I started the department here at St. John's, at least there used to be 2 or 3 patients like this in the ward every time referred from far away. But nowadays, I'm sure peripheral pediatricians are picking this up, treating appropriately, and patients don't even have to reach hematology. So this is the classical 14-year-old adolescent. It could be a girl or a boy, sometimes staying in a hostel, comes with a relatively long history, 2 months, lack of appetite, not very active, bit dull, very severe pallor, a mild tinge of icterus, otherwise systemic examination being very normal, and the classical, photo of the hyperpigmented knuckles, which you and I will be looking for carefully for any child with nutritional anemia to give us a clue that probably this is, B12 or folate deficiency. So the labs were again quite classical, very severe anemia. Again, we know that B12 deficiency or folate deficiency can cause low white cell count and low platelet count. The MCV was very, very classically very high, more than in adults, 100 is the cutoff, in children, 90 is the cutoff. So this was definitely very high. The peripheral smear showing the very classical picture of oval macrocytes and the hypersegmented neutrophils. So a very textbook description. So here again, B12 level was done. The level was very much below the 200 cutoff. So 96, this is whole B12. We'll come to that a little later. And so this was straightforward nutritional macrocytic anemia. Now, why have I called it macrocytic and not megaloblastic? Because I'm sure we recognize that megaloblastic is a word which we use to describe cells in the marrow. Otherwise, we will call this macrocytic. And because the whole clinical picture is fitting into the history of an adolescent who is probably not eating very well, the blood counts, the peripheral smear, and the B12 level. So all of these components, history, clinical examination, labs, peripheral smear, and B12. If all of them fit in, it's quite straightforward to diagnose a nutritional macrocytic anemia. So this child was treated with oral B12 and folate, did very well and recovered. But this poses some questions. What is the etiology in this child? Can I just presume that it is diet? Are these labs enough? Should I do a bone marrow? Should I really do a B12 level, or what are the fallacies of a B12 and folate level? So we'll come to some of this in today's discussion. Some more further questions for this very straightforward child. How do I administer the B12? Should I give it oral? Should I give it injectable? In which settings is injectable mandatory? In our country, of course, I'm sure a lot of you are also under pressure like us in hematology units. Doctor साहब इसको थोड़ा blood दे दो, इसको थोड़ा injection दे दो. So in which settings is this mandatory? Should I really transfuse this child? Right? We'll tackle all of these questions today. The second scenario, quite a different age, but also something which I'm sure many of you would have seen. An infant, a 9-month-old baby boy this time, comes to hospital because of fever, because that's often what triggers the coming into hospital. Irritability, poor feeding for almost 4 or 5 months. This is an exclusively breastfed baby. Mother has noticed that this baby is very dull and lost milestones recently. And a very classic spotter picture of a little puffy hands, very pale nails, and very dark complexion with hyperpigmentation. So again, this baby had again a very low hemoglobin, reasonably okay white cell count, borderline low platelet count, very high MCV, and the peripheral smear showing now a dimorphic anemia. So again, B12 levels were 55, mother's B12 here was 110. So based on the age of presentation, the cause of B12 would be very, very important. This is an infant, and so directly evaluation of the mother becomes important. So compare the first case with the second case. The first was an older child. This is an infant. So how should I start treatment? Is the treatment to be given differently? Are there any special precautions when we have very severe presentations in very young children? And by very young, I mean definitely infants and below around 1.5 to 2 years of age. And again, should we be under the pressure of the family to give blood transfusions, right? So I promise to tackle all of these questions. We'll quickly go over the burden of pediatric anemia. Jagdish sir, of course, will come back and tell us about iron deficiency. But when we talk about the second commonest important cause of nutrition anemia, definitely the B12 plus or minus folate deficiencies comes in. And sir himself has done a lot of pioneering work in this in terms of epidemiology to show that varying proportions of children with nutrition anemia have a coexistent deficiency of B12, folate, or both, which means many of the patients which you and I see as iron deficiency may have a coexistent B12 and folate. So I'm sure we've seen cases of patients where we've started on iron treatment very appropriately, microcytic anemia, iron stores are low, so we've started, and they've had some response but not responded very well. In those situations, we should think of B12 plus minus folate deficiency. So even in some of Sir's excellent papers, we found that almost 10 to 20% of patients in the community may have a coexisting deficiency, and that's something always to keep in mind. And the corollary also holds true. Let's say there's a child with typical B12 or folate deficiency. You remember I showed you the high MCV. That's the classical picture. Sometimes because of iron with B12 plus minus folate deficiency, the MCV may not be so high. And so then we are stuck saying, this is looking like nutrition anemia, लेकिन ये MCV normal कैसे हो गया? So a coexisting iron deficiency, and in our country, thalassemia trait is so common that you may not have a very large MCV. So these are the tricky bits that we need to cover. So why is it very important for pediatricians and hematologists to diagnose this entity? The importance, of course, is in the irreversible cognitive and neurodevelopmental deficits. You remember that second baby I showed you, 9-month old? There's a lot of work done from developing countries and a lot of papers from our own country. Many of you would have seen this in practice of infantile tremor syndrome. So these are the babies whose mothers are very nutritionally deficient, and unless we pick them up early, they may have irreversible neurological delays. If we pick them up quickly and treat them urgently, dramatically they respond. So this is one area where looking at that whole pattern of hyperpigmentation, borderline pancytopenia, very high MCV, peripheral smear in an infant. Look at B12 deficiency in the mother. In the papers from abroad, there may be B12 deficiency in the mother because of pernicious anemia. In our country, it's mostly nutrition. The second group, and a lot of you, I'm sure, are adolescent pediatricians also, and you'll be seeing a lot of nutritional anemia in the adolescents. And while iron deficiency is very, very critical in this group, so is B12 plus minus folate. With the children studying a lot for their exams, stress of all the coaching centers, junk food, eating food with only peers where children feel shy. I have an adolescent boy at home. They feel shy to take their dabba from home and go and eat healthy food because their friends are eating all sorts of stuff. So these are the typical group of children who land up and are at risk. The first child I showed you is the classical example. And while abroad, for adolescents who come in with severe, B12 deficiency, intrinsic factor deficiency becomes important. In our population, intrinsic factor deficiency isn't so important and will be considered only in two scenarios. One, suppose you have a child who keeps coming back with B12 deficiency, gets doses of B12, responds, but keeps coming back. Then we will think of intrinsic factor deficiency. The second situation is where there are other autoimmune pathologies. For example, let's say you have an adolescent with hypothyroidism, right? Or there is a child with vitiligo. These are also autoimmune diseases where the B12 deficiency may be because of intrinsic factor deficiency. One very important thing is that there is a high subclinical prevalence of cobalamin deficiency across the country. I want to stress on this fact because when you and I in practice see anemia and we are trying to sort out what is the cause of anemia and we do a B12 level, because B12 deficiency is so common in the community, we may get a low B12 level. But unless the history, clinical examination, indices, peripheral smear, unless they match, we should not be in a hurry to say this is only B12 deficiency. Right? So now coming to the causes. This is clearly from textbooks and we will go through which are the important ones. Cobalamin and the folate deficiency. Right? So So in cobalamin deficiency, when we talk about dietary origin, there's a lot of talk about vegetarianism versus non-vegetarian diets. And for the last 10 to 15 years, there has been clear data to say that even the non-vegetarians in a country like ours have such small quantities of non-vegetarian food that vegetarian versus non-vegetarian is not always a foolproof way of saying this child has a nutritional cause. It is very much possible for children who are taking small quantities of non-vegetarian food to also come in with B12 plus minus folate deficiency, right? Maternal factors becomes very important. We talked about how in the mother we have to check B12 levels, particularly in younger children. There's other two here, absorption failures and acquired malabsorption. These are less common. So congenital intrinsic factor deficiency, the absorption problem of Emerson Grassback, where you also have proteinuria in the urine. These are all, even in a hematology unit, maybe in about 10 years, you'll see one or two patients. Acquired malabsorption may not be so rare. For example, now with our colleagues in pediatric gastroenterology, we are diagnosing many of these refractory so-called nutrition anemias as either having some kind of a malabsorption. Some of them have an inflammatory bowel disease, which is not allowing either absorption of the nutrients or is causing a lot of inflammation. I'm sure Jagdish sir will talk about this in iron malabsorption. So the inflammatory bowel disease can have recurrent blood loss. It can prevent absorption of nutrients. And so absorption failures and gut pathologies are important, but to be considered only if your patient is not responding to routine treatment. Folate deficiency is not that common. It's a nutrient which is easily available. A lot of the families do give, milk products, and that has folate. But yes, what is very important about cobalamin and folate deficiency is what we've learned in our undergraduate and post-graduation in terms of when a child has any of these deficiencies and we start replacing the nutrient, it's very critical that it's the B12 which causes neurological manifestations, whereas the folate causes only hematological manifestations. And so, if we urgently give both B12 and folate, or we make the mistake of giving only folate to a deficient child, the neurological manifestations of B12 deficiency can worsen. So the IAP-PHO guidelines very clearly say that even if you have a doubt regarding the neurological manifestations in a patient, put the patient on B12 first. After a week to 2 weeks, that's the time to start the folate. So the pathophysiology, and you remember we spoke about two words. Macrocytosis is what we see in the blood. Megaloblastic is a word which refers to the marrow. So what really happens? We've learned this as UGs and PGs. There is a deficiency of folate and B12, which are both important for purine pyrimidine synthesis. If I have deficiency, my nucleus, which requires DNA material, is not able to mature. Primitive nuclei are bigger than mature nuclei. So what tends to happen? Look at the picture on top. The normal marrow with those three cells are the primitive normal erythroid precursors. And below you see very large, those are the megaloblasts with a bluish cytoplasm, which are the megaloblastic erythroid precursors. Now, when you have a picture like this, for labs which are very used to this, they will be clearly able to tell you that, this is megaloblastic anemia. But this sometimes can be tricky because children who have these type of large cells, they may have acute myeloid leukemia. Not the picture I've shown here. This is classical erythroid hyperplasia, lot of erythroid precursors, the bluish cytoplasm. But because severe anemia, thrombocytopenia is known in megaloblastic, aplastic anemia, and leukemias like AML, looking at the peripheral smear for blasts and looking at the marrow very, very carefully to differentiate, is this more like a megaloblastic or is this more like an AML, becomes very tricky. If you're working with a very good lab, this becomes quite straightforward. But we've had referrals of children where the initial diagnosis was a non-responsive B12 deficiency, which ultimately turned out to be AMA. Was it the mistake of the pediatrician? No, because many of these patients will have low B12 levels because B12 deficiency is common in the community. They will come with pancytopenia, and the peripheral smear may not show so many blasts. And unless the pathologist has looked at the marrow very, very carefully, we may miss. The other scenario is where, because of the pancytopenia, we have to very carefully rule out aplastic anemia. So coming back to the mucocutaneous markers, now that we know there are so many other dangerous differentials, how do we get clues? The classical knuckle and nail hyperpigmentation is well known. Mucosal atrophy, very red tongue, smooth tongue, that is also often seen. And this sallow complexion, that is slight puffiness of the face, mild icterus, this is not at all uncommon in megaloblastic anemia. And why does this icterus happen? Because the precursors of the red blood cells, which are trying to grow in the marrow, don't have enough nutrients and so break down. So there is a breakdown of red cells precursors within the marrow. And what does this lead to? This leads to a mild jaundice, just like a hemolytic anemia. So this also is something tricky for us in practice because many of these patients will have severe anemia. They'll come with a tinge of jaundice. If we do a total bili, conjugated bili, it will be unconjugated. So then we'll be little confused as to, is this more of a hemolytic anemia? Is this more of a B12 deficiency? That is where we'll have to look very carefully at the peripheral blood, look for oval macrocytes and hypersegmented neutrophils, and also very importantly, look at the retic count. If the retic count is low, then you know that the marrow is not producing cells well, and then you can give a therapeutic trial and see, is this patient truly megaloblastic anemia? Whereas if the retic count is high, then you know that probably this anemia and jaundice is part of a hemolytic anemia. Now be careful. Many times, by the time the child comes to you, a primary care doctor or their family physician may have said, आप B12 शुरू करो लेकिन pediatrician को भी एक बार दिखा लीजिए. If that has happened, then this child is already on folate and B12, and so the marrow has already started producing cells, and so the retic will actually start going up. So whenever you have a patient who has severe anemia and jaundice, there are two differentials, megaloblastic and hemolytic anemia. And then you have to look at the history, look at the corroborative findings. If the child obviously has a huge spleen, then you're looking more at a hemolytic anemia, and then put things together. The second set of clinical features I mentioned here, neurological regression, infantile tremor syndrome, and the mimic of malignancy. I described that to you in the previous slide, where because these patients come with severe anemia, severe thrombocytopenia, some of them may have a small liver and spleen palpable also. So if in doubt, if your center has capacity to do a marrow, please do that. But in most children with straightforward nutritional megaloblastic anemia, a marrow is not indicated. So how do we decide? Many times it's very reasonable to start a therapeutic trial, but follow up the patient very, very closely. At least every 1 to 2 weeks, we have to follow up patients because we know that in nutritional B12 folate deficiency, within 1 to 2 weeks, there'll be a very, very dramatic response. Within a day, the child starts feeling better. Within 3 to 5 days, the retic response comes up. And within 1 to 2 weeks, the hemoglobin also starts coming up. So this is an important chart which I have taken from the IAPPHO recommendations because it's very critical to know what is the normal MCV at different age groups. When we have newborns and infants, they have a physiological macrocytosis. But as the child grows older, the MCV becomes more like older or adolescents and adults. So the thumb rule for us could be 90 and for adults 100. So there are a few difficult scenarios which I'll quickly cover. One, I have already mentioned to you that sometimes you will expect a high MCV, but because of coexisting iron plus minus thal trait, you may not get a high MCV. So then how do we sort things out? Always remember that a high RDW will give you a clue to say that this is a nutritional anemia. Should we do B12 and folate levels? Are they helpful? Yes, but we should know the fallacies when doing these levels. If my history, clinical examination, peripheral smear is fitting into a nutritional megaloblastic anemia and my B12 level is low, then things are sorted out. But my B12 level need not be low because of even a single dose of oral or injectable B12. So this is a situation where B12 levels may be falsely normal or even high. The other part also I told you where because B12 deficiency is so common in the community, these other diseases like aplastic leukemia may incidentally also have a low B12 level. So when we do B12 or folate levels, because diet can change these levels so quickly, it is useful if they are low, but it does not rule out these diagnoses if it is normal or high. When you look at the textbook, there are a lot of these inborn errors of cobalamin, folate, metabolism. These are all quite rare. And if a child is not responding, if the child has, if the child has failure to thrive, recurrent seizures, developmental issues, and some of the specific entities like thiamine responsive megaloblastic anemia, where they will have diabetes, they will have hearing defect. So if this child looks like having a systemic disease, not growing well, some seizures going on, family history of a child which was lost due to seizures in infancy, these are very, very rare. And if you are suspecting something like this non-responsive child, then clearly a hematology referral is useful. I would request all the people in the audience to go back to the IAP PHO guidelines, which is perhaps one of the few guidelines around the world which gives us clear protocols of how to treat these patients. When you look at nutritional treatment with B12 and folate, literature has varying schedules. And why is it variable? Because the causes of deficiency is variable and there are no strict international guidelines for this. So when we look at the IAP PHO guidelines, we have clear guidelines as to how in a majority of patients, a few important thumb rules now. In a majority of patients, oral B12 with definitely oral folate is more than adequate because in our country, malabsorption and intrinsic factor deficiency is rare. Only if they're not responding or they have neurological manifestations or they have severe pancytopenia, you would fall back on injectable. Second thumb rule. What is the dose I should use? Younger the child, smaller the dose. Because if we give large doses to children, remember that B12 is also important for myelination. So if I suddenly flood the system with a lot of B12, I might worsen the neurological manifestations. Whereas if I go up slowly, chances of bad worsening of neurological manifestations is less. Third important thumb rule, whenever you're treating a younger child with B12, it can cause significant hypokalemia. So if a child comes in with severe anemia, useful to admit, start on these therapies, monitor for neurological manifestations, monitor for potassium, and then only once the child is better, taking well orally, potassium stable, then to discharge. Folate, most of the time oral, it's only in the very small proportion of children with metabolic errors, inborn errors of immunity that you need injectable folate. An important rule I've already mentioned, B12 first, because we all recognize that, and if we give folate without giving B12, I will worsen my neurological manifestations. Hypokalemia I've talked about, and whenever treating infants, you need to monitor them and reassure the family that they may become sick. I leave you with just these two cases, both 15-year-old children with severe pallor, pancytopenia, no other findings, and give you 10 seconds to look at this picture of pancytopenia. Case 3 has a high RDW, whereas case 4 has a normal RDW. Peripheral smear not very helpful. So one thumb rule for us, anemia associated with other cell lines clearly is pancytopenia. But if we have oval macrocytes and hypersegmented, we don't need to proceed further. And most of those children will have a high RDW. Whereas if I have a high MCV with a normal RDW, I do need to think of marrow disease. A lot of aplastic anemias in children, acquired aplastic, inherited marrow failures, all of these may have a macrocytosis. So either if they don't respond to your therapeutic trial, or when they come in, they already come with a normal RDW, safer to and indicated to do a marrow. Last case, 5-year-old child, a 10-year-old boy who came in with hyperpigmented knuckles, had got blood 3 months ago, pancytopenia, MCV on the higher side. My postgraduate said this must be B12, but this child had other subtle manifestations, was not growing well, had a single kidney, and ultimately was diagnosed as Fanconi's anemia. So I hope I've shown you that many of these common findings, hyperpigmentation, pancytopenia, mild jaundice, high MCV, they all may definitely be megaloblastic anemia. But I'll leave you with these important practicing rules for us, which will help us not make errors. Look beyond MCV. Always look for hypersegmented neutrophils and oval macrocytes, because just a high MCV does not mean megaloblastic anemia. Always correct B12 first and then start folate. Oral B12 is sufficient in a majority of patients, particularly breastfed infants. In our country, how we are putting a lot of focus on iron, we should also focus on young babies and mothers with B12. Restrict transfusions. Even a single transfusion can cause problems. So if a child is stable, only if there's hemodynamic problems do we need to really transfuse these patients. And most critical, if there's only one thing which you take home from this presentation, whenever you suspect and treat megaloblastic, please follow up the blood counts. Very important, because there are other more dangerous diagnoses which can fool you and me. I'll stop here and thank the audience for a patient listening and look forward to Jagdish sir's presentation. Thank you.
Thank you, Dr. Anand, for a wonderful presentation. And I request Dr. Manas to request Dr. Jagdish sir to please share his.
Thank you, Anand. It was a lovely presentation, and I'm sure the delegates have been benefited about, thoughts on megaloblastic anemia. Please remember that we'll have a post-test at the end, so please listen to the lectures carefully, because I think most of the questions will be from those. Although I did not know the content, but still, some of the questions that I have added in the post-test are actually from the same, topics that they have been describing. So listen to the lectures very carefully. And now we'll have Professor Jagdish Chandra. Thank you, sir, for joining us. And as always, it's a pleasure to listen to you, especially on nutritional anemia, because I think you have not only taught India, you have taught the world how to manage these patients in the right way. And your publications have gone, very far and wide reach to make sure that nutritional anemia is eliminated from this world in the years to come. It's a big battle, but I think slowly we are moving towards that. So over to Jagdish Chandra sir for iron deficiency anemia.
Dr. Jagdish Chandra sir is currently the chairperson of the nutrition group of Central IAP, National IAP.
Thank you, Dr. Manas and Dr. Ajay, for those very kind words of introduction, and really wonderful talk that we had from Dr. Anand. In fact, I almost forgot that I am going to present next to him. So anyway, I'm I'm going to present the microcytic anemia, that is the iron deficiency anemia. Um, and as is my screen visible now?
Yes, sir. So please make it full screen.
Yeah, sure. Yeah. So just it was highlighted
Yes,
that it's very common condition, and I take you to this most important, most significant historical event in the previous century. The man steps onto the moon, and at this time in 1970, we started the anemia prophylaxis or anemia control program. All these strategies you can see, though in 23 our satellites also landed up on the moon, but anemia persisted despite so many interventions. The anemia prophylaxis control, national policy, national action plan, etc., etc., and finally landing up with the Hindi version of these programs, Anemia Mukt Bharat, and now last month it has been changed to Anemia Mukt Bharat Abhiyan. So in a mission mode, this is being talked about, but anemia prevalence, particularly in the most vulnerable of pediatric age group, the 6 months to 59 months, it stays very high. Nearly two-thirds to three-fourths of the children are anemic. And if you go by this NNS data on etiology, you will see that uh, the the anemia in a large majority of these cases is because of the nutritional causes. Though the figures here are nearly 70% or 65% and 51%, but I'm sure more than this are the causes for the nutritional anemia is the cause for an iron deficiency under 5 years is the most common cause, while folate and B12 deficiency was higher among the school-going and adolescent age group. Dr. Anand also highlighted the presence of B12 and folate deficiency amongst the adolescent age group. So I will discuss this problem of an iron deficiency anemia in with cases. So this is a child who is 11 months male, though came with fever and cough for 3 days, weighing 8.3 kg, found to be moderately pale, largely milk-fed, occasional biscuits or pieces of chapati, no liver spleen enlargement, and there's a history of breath-holding spells, 3 such episodes over last 2 months. So you can see that there is pallor, despite moderate pallor, the child was not brought to the hospital. Only the fever and cough uh, brought him to the hospital. Second important thing in this child is there is no liver and spleen enlargement, though there is moderate anemia. And third is that history of breath holding spells. So this child's hemogram showed low MCV, low MCH, and low MCHC with a hemoglobin of 7.3. RBC count was 3.3 million, and the PS was microcytic hypochromic. So physical examination in cases with iron deficiency anemia is usually normal. There is pallor or mild liver and spleen palpable can be there, no bleeds, no liver spleen enlargement, and no lymphadenopathy. Though features described like koilonychia is extremely rare and probably very late manifestation, but in some cases you might find clubbing, and then you have to think of celiac disease as a cause of iron deficiency anemia. So the children who are born preterm or small for date, those who are largely fed on milk with nil or inadequate complementary feeding, no iron supplements given, repeated episodes of diarrhea, and children with pica, breath holding spells, or cases with febrile seizure, they are more likely to be having uh, iron deficiency anemia. So these pica, breath holding spells, and febrile seizure they are now known associated features of iron deficiency. Cause and effect relationship is there, and of late, the iron deficiency has been found in more and more cases of the attention deficit and hyperactivity disorders. You can see here in one study, the serum ferritin less than 30 nanogram was found in 84% of children with ADHD, while controls had only 18%, and very low serum ferritin of less than 15 occurred 32% of ADHD and controls just 3%. So similar data from one study from our country as well, which is listed as 8 out of 119 of normal children had iron deficiency, and 22% of ADHD patients had iron deficiency. So causes, in most of the instances, the cause of iron deficiency is poor dietary intake because of poverty, top feeding of infants, poor complementary feeding practices, and food fats, particularly in adolescents, malabsorption, recurrent diarrheal disease or celiac, blood loss occurring because of the GI losses in liver disease, menstrual blood loss, hereditary conditions, and Meckel's diverticulum, and then finally genetic conditions like IRIDA and DMT deficiency. So coming back to this case where the MCV, MCH, and MCHC was low, and with these observations of the diet which was inadequate and low liver and spleen enlargement and history of breath holding space, which makes him more likely to have iron deficiency anemia. So do we need further investigations in this child, or we start the treatment? So the recommendations from our group uh, is that these are the cutoffs which I think Dr. Anand also showed for macrocytosis and macrocytosis. So for the diagnosis, this triad of low MCV, low MCH, and MCS is enough. And in such cases, response to iron therapy should be documented for confirmation of the diagnosis. However, serum ferritin should be the first test whenever you want to investigate further. And in situation where serum ferritin results are equivocal, then you look at the transferrin saturation and the newer tests which have become available, that is ferritic hemoglobin and percentage of hypochromic cells. These are few tests which are available. But currently, serum ferritin should be done if it is available and if in private setup, if the patients can afford, so that the diagnosis is made on a certain ground. Now, serum ferritin cutoffs are described under 5 years less than 12 and more than 5 years less than 15 microgram per liter, or you can convert it to nanogram per ml. And when we order the investigations for iron deficiency anemia, please do not order iron studies alone. Iron alone should not never be done, and this is required only when you are trying to calculate the transferrin saturation in cases where the ferritin was equivocal. Now, over the last 1.5 decades, a lot of literature has cropped up regarding the cutoff of ferritin. So, and this is being questioned whether this 12 or 15 nanogram or 30 nanogram in cases with infection, that should be the really cutoff. So, my just information I want to give is that ferritin cutoffs are not something which is cast in stone. One has to really see that for instance, say in a child who is suspected to have iron deficiency anemia on the basis of history, physical examination, and your CBC, if the ferritin is at 20, 25, you just don't discard the diagnosis of iron deficiency. So the cutoffs are probably in the process of getting revised by the WHO. These tests are also available. You can see on this the report that I have shown, the underlying reticulocyte hemoglobin. I get the point here. Yeah, so this reticulocyte hemoglobin is available in several 7-part analyzers. So these tests also do help if the ferritin is not lower. Now, how do we treat such cases with iron deficiency anemia? Going by the guidelines, the comprehensive treatment should include providing iron therapy, remove the secondary cause if it is found, dietary modifications, and periodic follow-up for assessment of therapeutic response. And after completion of your treatment, even after the patient has received treatment to replenish the store, please advise them to follow up with Anemia Mukt Bharat Abhiyan IFA supplementation, so that further occurrence is not there. So these are the various preparations: sulfate, fumarate, gluconate, citrate, etc. And oral treatment is recommended, which is safe, effective, and economical, and leads to rapid improvement. And of course, it is convenient for the parents. So most preparations, we know that they mention the elemental iron per 5 ml of the syrup, or 1 ml of the drops. So the recommendation said that ferrous sulfate, fumarate, or gluconate should be used as the first line treatment with a dose of 2 to 3 milligram per kg. Single daily dose was recommended, and 2 to 3 months after the HB normalizes. We will look at this. What does this mean? 2 to 3 months after HB normalizes. So follow up is being now talked about the Anemia Mukt Bharat Abhiyan. There was a T3 strategy, that is test, treat, and talk. But now they have gone on to T4 strategy, that is test, treat, talk, and track. That is continue follow up the patients till the anemia gets resolved. So follow up visits for severe anemia on day 7 and moderate anemia, mild anemia day 14. And look at during the follow up visits for compliance, any adverse effect which might influence the compliance, whether the patient is tolerating the therapy or not, and clinical improvement, and emphasize the dietary change and dietary diversity. So this is the expected response to the treatment. Within a day of starting the treatment, there is subjective improvement. There is initial bone marrow response and erythroid hyperplasia in 2 to 3 days, and subsequently the retic increases, and from 4 to 30 days, there is increase in the hemoglobin. So I was talking about what should be the duration of therapy. That is when the desired hemoglobin is reached. After that, you have to, you know, give further 2 to 3 months for replenishing the stores. Now, for that desired hemoglobin should not be the cutoff for the diagnosis of anemia. It should be the mean hemoglobin. You can see the difference between the mean hemoglobin and the lower limit, that is 12.5. Say for this age group, 2.5 to 1.9 years, that is 12.5 is the mean, though the lower limit for the diagnosis of anemia is the 11. Same way, 12.5, 13, 13.5. So this should be the target hemoglobin for before the target the replenishment of the stores. And you can see that in these graphs, you can see in both the studies, these are from India, within 3 months, the hemoglobin has risen to 12 grams, and similarly 12.5 grams in the another study in over 8 weeks time. So with this background of how do we diagnose and manage the iron deficiency, let us look at some more cases. This is a 2-year-old male child. On PSC for hernia surgery, the hemoglobin was found to be 8.9 gram percent. He was treated with iron syrup, and it was thought that in nearly 1.5 to 2 months, the hemoglobin would be above 10. So the surgery could be taken up, but HB remains the same, and then it landed up with the hematologist. You can see here the HB of 8.9, MCV 60, MCH 18, MCSC 31.2, RBC count 5.9, and this is something which you should notice that this is remarkably high. In cases of iron deficiency, you do not get such high RBC count. It would be proportionately decreased proportion to the anemia. So what do we do next? So a comparison of thaltrate versus iron deficiency, the microcytosis and the lowering of MCHC and MCH would be almost similar, but the RBC count would be different. In thaltrate, it would be more than 5 million, and in iron deficiency, it would be reduced. And RDW is normal in thalassemia trait, and it is increased in iron deficiency. So these could be the differences between the two, and this is the chart, the RDW cutoffs and TRBC cutoff, and then you can calculate the Menzer index, that is MCV divided by total red cell count, and finally you can confirm the diagnosis by doing HPLC or electrophoresis, which would demonstrate elevated A2. So causes of non-response could be non-compliance, medication error, medication interaction, diet, malabsorption because of celiac disease or PPI treatment, etc., ongoing blood losses, that is mucus diverticulum, worms, inflammatory bowel disease, losses in the menstrual, pulmonary, or urinary losses, and hereditary conditions. So the other could be coexistent infections, coexistent deficiencies of folate and B12, which Dr. Anand also mentioned, and then finally incorrect diagnosis that we saw in this child, thalassemia minor, sideroblastic CKD, etc., and the genetic causes of the microcytic anemia. So, moving on to this case, that is a 6-year-old child. He is having this pallor since the age of 1 year, progressive pallor. It has been seen by several doctors and has been the history has been detailed here. No history of worms or alien itching, no pica, diet is normal, no diarrhea, no GI bleed, no recurrent infections, no jaundice, no bleeding manifestation, no significant family history. So, on examination, moderate pallor, hemolytic facies were not there, no jaundice, bleeding, or edema, lymphadenopathy. The borderline normal weight and height, and no organomegaly. The hemoglobin, when the child presented, was 7.2 at a count of 1.9, and after the 6 weeks of treatment with 4 milligram per kg dose, it increased to 7.9 only. Only very, very minimal response. In this time, the hemoglobin should have gone to something like 9 or so. So the further workup included the checking of compliance, that is dose formulation. Serum ferritin was 47, KFT normal, infections excluded, urine culture, 1-2 negative, X-ray normal. The stool for occult blood was negative, the celiac was ruled out, and technetium 99 scan was negative, and HPLC was normal. So then the doctors proceeded with the evaluation of IRIDA, and NGS for evaluation of IRD was done, which showed compound heterozygosity for mutation in TMPRSS6 gene, which is a pathogenic mutation for confirmation of the diagnosis of IRIDA. So this IRIDA is a rare form of inherited iron metabolism defect, which was described almost 50 years ago. But the causative mutation was discovered only in 2008. This is the mutation in TMPRSS6 gene, which is on chromosome 22, which results in persistence of high hepcidin in the phase of low body iron, and there are several mutations are now identified. Now, this is a study from PGI Chandigarh by Dr. Deepak Bansal's team. They looked at cases of anemia, 550 cases with variable degree of anemia. They were treated with 3 milligram per kg of iron for 4 to 6 weeks, and they diagnosed iron refractoriness if the hemoglobin was less than 1 gram increase over 4 weeks period. So there was 60 such cases. In these cases, they uh, uh, excluded the other causes like the CRP was normal, TTG was normal, and normal HbA2. Now then they looked at the profile, clinical profile of these cases, and the IRIDA phenotype was seen in 23 of these 60 cases. That is low HB, low MCV, and low MCH. The less severe anemia compared to the other groups. So in this group was 8.2, and low or very low serum iron, but ferritin being high, normal 40.24 compared to 2.8 in the other group. So Epstein was done. Epstein was 28 compared to 17 in the other group. And then mutation was looked at in 20 cases. So 11 of these 20 cases, that is 55%, or you can say 11 of the 60 cases who were non-responder, the RIDA mutations were found. So this condition does occur in our country, but it is not that when there is iron refractoriness, you just order the investigations for IRIDA. So just one more case I would present in 3 to 4 slides. That is a 5-month-old girl, resident of Samastipur, Bihar, brought to Kalavati Student Children Hospital with progressive pallor 2 months, irritability for 4 to 5 days. There was no fever, no abdominal distension or neck masses, no bleeding from any side, no bruises or no jaundice. Child appeared pale and irritable with the tachycardia and tachypnea. They were basal rails, they were periorbital puffiness, and the growth parameters were moderate undernutrition. The abdomen was soft and non-tender, liver 3 centimeters soft, but the spleen was not palpable. Bilateral cracks were there, CVS, neurological and neurological examination was normal. So this child's hemogram showed a very low hemoglobin of 1.9. The MCV was 74. So this is the age when some cases of thalassemia also can present, but there is no splenomegaly, which should have been there if it was a case of thalassemia. So other investigations, the bilirubin was normal, the urea creatinine was normal, and quantitative CRP was just 5 milligram. So provisional diagnosis of severe anemia and congestive heart failure with underweight stunting, hemolytic anemias, infections like malaria, chronic blood loss, and hypoplastic anemia, they were considered. So retic count of this patient was 11% and corrected was 1.8% only. So DCT, ICT were negative. Malarial parasite was not seen. The RMAT was also negative. INR was 1.2. Vitamin B12 and folate were normal, but ferritin was 7.4 nanogram, very, very low. And HPLC of the parents and the child both were normal. Now, over the follow-up in 2 weeks, 3 weeks time rather, 2 weeks rather, from 18th to 31st, this child required 3 transfusions. So then the attention was drawn to this. Probably there is a blood loss, and there was no clinically overt bleeding. Urine microscopy did not show any RBCs. Gross stool examination revealed blackish and semi-solid stools. Stool for occurred blood was positive. Ultrasound normal. Technician scan was normal. So the endoscopy was done, and to the surprise of the gastroenterologist, the ankylostoma duodenale was seen. So this was the real perpetrator for the anemia of this child. I particularly put up this case so that we should not forget our old foes. These are still operating in some cases. So just to highlight that anemia due to nutritional causes, generally we say that 6 months onwards, these are the causes, and all the preventive the preventive programs, they all highlight the interventions above the age of 6 months. But these are the 4 or 5 studies over the last 10 years or so from India. One of them, the first one is again from PGI Chandigarh. The iron deficiency and iron deficiency anemia and other anemia because of nutritional causes is being reported in up to two-thirds of the cases in 4 to 5 months, 4 to 6 months of age. So I think this is probably the last slide. Just to summarize, the IDA can be diagnosed based on the CBC, but one can do serum ferritin and careful interpretation of this. Treat with 2 to 3 milligram per kg dose. Target hemoglobin should not be the cutoff uh, 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 for this defining anemia, rather than it should be mean hemoglobin. Follow up for response and document it. Look for the cause if not responding adequately. Look for the alternative diagnosis in responder. IRIDA is seen in India, but in minority of cases. Don't forget the old foes. The parasites can still be active, and nutritional anemia may occur under 6 months of age. For the prevention, one can check the hemoglobin at 9 months and 18 months visit for the vaccinations. And now currently the ICMR is coming up with a recommendation that the hemoglobin should be checked at every health contact if it has not been done in previous 6 months and it has not been addressed if it was done in previous 6 months. And they attach the patient to the AMB Abhiyan in the community for continued prophylaxis. So I thank acknowledge the contribution of cases, Dr. Praveen Kumar, Dr. Manas Kalra, and Dr. Mukesh Dhankar. And thank you very much for giving this opportunity to me for discuss iron deficiency anemia. Thank you very much.
Thank you, sir. And it's a wonderful presentation by uh, Dr. Prakash, and very nicely covered the topic. And I hope the all delegate will be get benefited. And as usual, sir, Dr. Chandra is always a good orator and a good teacher, and teachers of teacher, we can say. And it's a wonderful. Well, I cannot remark it's this excellent part. And now over to Dr. Manas Kalra, sir, for taking comments.
And thank you, Jagdish Chandra sir. Thank you, Anand, for this wonderful session on iron deficiency and B12 deficiency. There are many comments and questions in the chat box. I think Anand has answered a few. If there are any more, we'll be happy to take those. There's a question on, can albendazole be given in less than 6 months routinely? Anybody would like to answer?
Well, our AMBA guidelines do not say under 6 months. This is twice a year after the age of 6 months.
We don't give for very younger kids.
So I
Blood
just have a
transfusion.
comment to make.
Yes.
Sir, is it our obsession with milk is leading to many cases of iron deficiency in milk? Like mothers are really obsessed, even grandmothers, especially the grandmothers.
Yeah, I think that is one reason. And when the child is given a lot of milk, there is hardly any appetite left for consuming the complementary feeding. So it is inadequacy of the complementary feeding. And actually, if you look at the over the 6 decades interventions with IFA supplementation, this has not been effective primarily because the implementation problems. So sometimes the drug is not there, sometimes it is not distributed. If it is distributed, the families are not motivated enough to take this the drug continuously. So these are
Does the milk also lead to
clearly
microhemorrhages and blood loss?
uh, well, in very young children it might, but it is known that the cow's milk intolerance is not all that rare. A few years ago, it was said that it does not occur in India, so it is not the case right now. So if you introduce the animal milk too early in the day, say particularly before the 6 months, there are problems.
Anand, can you answer the question of what is the blood transfusion cutoff for B12? I think that's a recurrent theme. Many people want to know that.
Correct. I'm glad that question came up, and I must compliment the audience because there are so many questions. It's very nice to interact. So I think there is no one single hemoglobin cutoff. As far as possible, we should avoid blood transfusions in nutritional anemia because whether it is iron deficiency or B12 folate deficiency, within a few days of starting therapy, the hemoglobin usually does come up. Having said that, I'm sure there are children we will see with very low hemoglobins. Somebody asked 1.2 hemoglobin, which can happen. Yes. Many of these children come to us when they're having an intercurrent infection, which brings them to hospital. And incidentally, we also pick up the severe nutritional anemia. So the general rule is avoid transfusions. However, if the child has a cardiorespiratory concern, if the child has a coexisting severe infection, if the hemoglobin is, let us say, less than 3 or 4, I don't want to put a certain number on it because then it becomes a habit to just transfuse. But in those specific situations, I would go ahead and give transfusions, particularly if there's a cardiorespiratory compromise. As far
Which
as
one is better,
avoid follow,
cyanocobalamin or methylcobalamin? Which one is better?
there is no benefit or deficiency of either of the two. Methylcobalamin is available. It's quite cheap. It's available without any other nutrients added to it. So that is what we routinely use in practice.
So, Jagdish sir, a lot of people want to know when to do HPLC. In all these microcytic anemias, where you don't want to miss thal minor, you don't want to miss alpha thal. When to do HPLC in microcytosis?
So I think I presented one case where the non-response, because of non-response, the review of hemoglobin was the CBC was there, and then the trait was suspected and it was done. And similarly, what the Dr. Bansal has done in the PGI study, when there was no response, only in those cases, and there also one can look at the CBC if it is suggesting that beta thalassemia trait could be there, like the RBC count being very high and looking at the Menzer, if they are suggesting the RDW is low, so in those situations, doing HPLC is required. It should not be done upfront. There's no role, no place of doing this upfront.
Sure. And iron refractory, iron deficiency, what is the treatment?
Parenteral iron. The high dosage of oral iron also do help, but it is the parenteral iron which is helpful in most of the instances.
So I think parenteral iron in most cases is helpful in IRIDA. There's this question about so many oral and injectable B12 are available. B12 deficiency treatment is little complicated. I just want to say that, whether it is iron deficiency or B12 deficiency, the most important treatment is that we give treatment. We make sure that the iron is going inside the body. That is the biggest problem. Even if you give at 1 mg per kg, but the child is taking it regularly, it will help. The problem is that the compliance is not good and people stop giving it. I think most important is start low, with a very low dose and make sure that the patient is compliant, and you'll have a good outcome. So
May
there
I
is
request?
question.
Yes.
Yes,
Yes.
Dr. Dinesh. Yes.
Dr. Manas, actually, we have a constraint of time, and the number of questions are there. So we have to stick to the schedule. Before that, I must welcome our past secretary, Dr. Shamsundar Meena is also here. I would like to take one line comment from Dr. Meena, because he is a very dear person to me also. Please, Dr. Meena.
Thank you, Dr. Dinesh. Very good morning to all faculties as well as office bearer and all beloved delegates. Remaining question will take on the WhatsApp group. That is a better way to save the
Yes.
time. I just
Sure.
put the quick message. As the Manas said, one of the audience also asked about what is the management of the refractory anemia. Before jump on the parenteral therapy, must be rule out the GI malabsorption.
Yeah, absolutely.
As they being gastroenterologist, face the many cases, they already even get the bone marrow call, parenteral iron therapy, and they easily diagnosed by the endoscopy as a celiac disease. That is the important thing.
Thank you so much.
Other answer from the Dr. Ajay that what about the milk? Milk or bovine milk allergy is not a too much common entity in the Indians. Nowadays, yeah, due to the easily availability of the endoscopy facility, we are able to make the diagnosis, but don't forget that the common presentation is like the colitis or GRD reflex, not anemia. So if you are thinking, then you should relook the other associated symptom. That is very important thing. And thank you, Dr. Anand. You really include the very practical aspect for the postgraduate benefit. What the cause of the pancytopenia, jaundice, refractory anemia, what are the things? That is excellent talk. And thank you, sir.
Thank you, Dr. Meena. And with the permission of our coordinator, Dr. Manas Kalra sir, and the speakers, can I say vote of thanks from Dr. Ravinder? Because we are running little late. Ideally, we have to close the session by 10:10 maximum.
Dinesh, should I share the answers also in the WhatsApp group for the post test?
Yes.
Okay.
Yes,
Okay.
sir.
I'll
Yes, sir.
share
You
it in the
can do
WhatsApp
all
group.
in WhatsApp.
Okay.
And I request
Sure.
all delegate. I'm very sorry for the delegate because there are a lot of questions in the chat box. So I request all delegate to please put their all queries in the delegate WhatsApp group so that we can answer them. Now I welcome our treasurer cum secretary like Dr. Ravinder sir. I think he's on second call. Dr. Ravinder, are you there? Dr. Ravinder, are you there?
Hi.
Yes. I welcome you, sir. Dr. Ravinder is our treasurer cum secretary elect. So I request Dr. Ravinder to say vote of thanks to the all esteemed faculty and delegate. Over to you, sir.
Hi, good morning all, and thank you, IIT Delhi, our President, Secretary Manas, always leading from the front now in hemato-oncology. And thank you, Dr. Anand, very good case presentation, and Jagdish, sir, always a very crisp talk and crisp message. Although I have a couple of queries, but already Dinesh has said no query at all. So I'll directly ask Dr. Jagdish, and Manas is always there. And I'm happy to see Jagdish sir acknowledging our Dr. Mukesh Dhansal and Dr. Preen Kumar also for case sharing. I think both of them has shared some very interesting case. So thank you all. I hope in next couple of meetings,
Thank you very much.
interactive. A very
Thank you, sir.
interactive.
Thank you so much, and have a very good day.
Thank you.
Enjoy your Sunday. Thank you.
Thank you.